Hello and welcome to the COMLEX Instant Podcast. Today we're going to be talking about congenital heart disease and we're going to be reviewing coarctation of the aorta. For coarctation, remember that infants may have some signs of severe heart failure, usually signs of systemic hypertension, and again, what happens here is that there's a localized narrowing of the aortic arch just distal to the origin of the subclavian artery, and its development is thought to be related to some sort of an accessory ductal material that contracts soon after birth. Therefore, it is not usually present in the fetus. And collateral circulation develops around the coarctation through the intercostal arteries and the branches of the subclavian arteries and can result in a lower transcoarctation gradient. And finally, the coarctation is a cause of secondary hypertension, and the renin-angiotensin system is reset, and it contributes to the hypertension. What happens also is that the elevated blood pressure, it may not return to the normal levels after the repair. And some of the general considerations include looking for patients with an associated bicuspid aortic valve, patients with a web-necked exokaryotype and Turner syndrome, absent or weak femoral pulses, delayed palpable pulse between the femoral and brachial artery. Again, that's an important point on the boards on physical exam. And in some patients, the coarctation murmur can be heard in the back. And in severe coarctation, the continuous murmurs of the collaterals around the coarctation can be heard in the back as well. Systolic pressure is higher in the upper extremities than lower extremities, common sign, and EKG will show left ventricular hypertrophy, signs of rib notching on chest x-ray, and again for the board exam, as with most valvular diseases, the echo is definitely the choice of tests that you want to select. And for the treatment, keep in mind that the resection of the coarctation site has surgical implications, and so the percutaneous interventional procedure of choice is usually stenting when it's possible. Also understand that recently self-expanding and balloon-capable stents have been introduced, but for the board exam purposes, keep in mind that stenting is usually an option. And also that the cardiac failure is a common sign in infancy, and keep in mind that patients with a gradient of greater than 20 mmHg should be considered for any sort of a intervention. Okay, so that's one of the key points that you want to look for on the board exam question. That was an overview of the coarctation of the aorta. Now let's talk a little bit about the ventricular septal defect. And the ventricular septal defect is actually a restrictive condition. And what happens is that a restrictive ventricular septal defect is small and it makes a loud murmur than an unrestricted one. Also, the small defects are usually asymptomatic, whereas the larger defects may be, show signs of pulmonary hypertension if it's not repaired. And so some of the key things you want to remember are that the EKG can show signs of left ventricular hypertrophy, right ventricular hypertrophy, or both. And there's several grades of VSDs, and a grade 2 to 4 can have a pansystolic murmur, maximal at the left sternal border, and there's also an associated thrill sometimes. Echo is diagnostic, and the higher gradient across the septum, the smaller the left to right shunt becomes. Now, what are some of the other characteristics? Well, the clinical features depend on the size of the defect and the presence or the absence of right ventricular outflow obstruction or an increased pulmonary vascular resistance. Keep in mind, as we mentioned, small shunts are associated with loud, harsh holosystolic murmurs in the left, third, and fourth interspaces along the sternum. Larger shunts can create right ventricular volume and pressure overload. Also, if the pulmonary hypertension occurs, high pressure pulmonic regurgitation may result. And as we had mentioned, the echo is again the test of choice. Well, the EKG will show signs of combined right and left ventricular hypertrophy. And what do you see on that? Well, what you would have is several things. The ST segment depression is usually present in leads 2, 3, and AVF and V6. And the combination of this right axis deviation and the left ventricular hypertrophy is a reliable indicator for biventricular hypertrophy. So this is some of the key things that you want to remember for a VSD. Alright, that's one of the key findings. Echo is diagnostic as usual, and the treatment guidelines, the newest treatment guidelines, recently updated from the American Heart Association Task Force on Practice Guidelines, published in 2008, say the following. Medical management, Class 2B recommendation is, pulmonic vasodilator therapy is appropriate for adults with a VSD and severe pulmonary hypertension. Also, surgical management, Class 1 recommendation is closure is indicated when the left to right shunt ratio is greater than 2, or there is a clinical left ventricular volume overload. And surgical management Class 2B is closure is reasonable if the left to right shunt is greater than 1.5 and the pulmonary pressure and the pulmonary vascular resistance are less than 2/3 of the systemic pressure or the systemic vascular resistance. And the closure is also reasonable if the shunt ratio is greater than 1.5. So those are some of the key things that we had mentioned. And the one thing you want to remember is that surgical repair of a VSD is of a low-risk procedure unless there's significant Eisenmenger physiology. And currently, several new percutaneous closure devices are under construction for non-surgical closure of VSDs. That was a board review of VSDs and also of coarctation. Please visit COMLEXFlashcards.com for additional board review lectures on the COMLEX board exam, and good luck in your preparation for the boards.